And now I'm going to have the pleasure of introducing Kathleen, Dr. Kathleen Hunter from Edmonton. I'm not sure, many of you have probably met her and heard her speak before. She's an associate professor with the Faculty of Nursing at the U of A, and she's also a nurse practitioner and a nurse continence advisor. She's taken the program herself at the Glen Rose Hospital, their continence clinic in Edmonton, and she's been involved in many research projects. I know she's just completing a year of sabbatical, so I thank her for taking the time out to come and do this presentation for us. So she's going to talk about some of the changes that are happening in the nursing profession across our country in terms of nurses potentially being given the right to prescribe. And I'm not talking about the NPs, I'm talking about just registered nurses. So I'm very interested, and I think we all are, to hear. So welcome, Kathleen.
Thank you. Thanks, Grace. So I'm going to apologize for my voice. Last weekend I had no voice, and I was panicking. I have my water, I've taken my Benylin, and hopefully my voice is going to last through all of this. Yep, good. Okay, so RN prescribing, starting to be a hot topic here in Canada, and after a presentation, a joint presentation that Grace and Frankie and I did at the ICS in Montreal, Grace had approached me to talk about this subject here with the NCA group. So pretty simple. I'm going to go over a little bit of the international scene and then go through in more detail some of the things that are happening here in Canada. And then I want to spend a little time at the end talking about what's really important for this group is what are the implications for the NCAs and how might this unfold in the future. So what is nurse prescribing? Well, there's absolutely no consensus on this. How's that? Generally, it refers to an RN, and Crozen, who's a nurse from the Netherlands who's done a lot of work in there, says it's usually associated RNs with baccalaureate or nurse specialists at a master's level in most countries, and she's done a lot of work internationally on this. But the issue is, of course, every country has its own registration system and levels of nursing, so this really complicates having any kind of international idea or consensus on what nurse prescribing is and nursing roles. But in general, we can say it is the ability to order diagnostic tests and prescribe pharmaceuticals, and in some jurisdictions, also non-pharmaceutical management interventions. There's generally 3 models of nurse prescribing that are out in the literature. The first one is independent prescribing. Second, supplementary, and the third one known as prescribing based on a patient group. So I'll just talk about those a little bit more in detail so we can think about those roles. So independent prescribing is where we have a practitioner who is qualified in the eyes of their jurisdiction, again saying because we don't have any international, and I'm going to tell you we don't have a national consensus on this either, but responsible for a clinical assessment, making a diagnosis, and then determining decisions about treatment and management of conditions, both, as I said, pharmaceutical and non-pharmacological. This can involve using a limited formulary or an open formulary. And it's also known as initial or autonomous or substitutive or open prescribing. So the role that we think about here in Canada for independent prescribing tends to be the nurse practitioners. In most jurisdictions, that's the role that they have legal jurisdiction to do. Supplementary prescribing is where we have a partnership or collaboration or a consultative process between an independent prescriber, so in this country that could be a physician or a nurse practitioner, and a supplementary prescriber. And they work together to manage the patient's condition and also work within that patient's agreement, as we all do when we do our work, right? We need to get our patient, make sure what we're doing the patient agrees with. Again, this can be an open formulary or a limited formulary. And it's also known as dependent or collaborative or semi-autonomous or a complementary type of prescribing. The last type of prescribing is not recognized by everybody who writes on this topic as really a prescriptive role. It's the supply and administration of specific medications in specific situations. And in Canada, we've had this for many years. I think about the nurses who work up in rural and remote areas, especially up north. So the FNI nurses have protocols that they can follow and dispense medications for specific conditions. Okay. These are also known as group protocols. Nurse prescribing has been growing internationally. Most of the countries where this is now legislated in some way include Australia, Canada's in there, Hong Kong, Ireland, Jamaica, the Netherlands, New Zealand, South Africa, Spain, Sweden. I'll give you the rest, US. And recently, Finland has come on board as well. But there's great variation from country to country. And if you're interested in this, I suggest you look at the work of Gieland, who's done some interesting documentation on what's been going around on an international perspective. So, as we said, internationally, a variety of titles in education. And the requirements are very, very different in different countries, and it's really hard to compare different countries. So if I have a chance to meet Dr. Crozen, I'll have to congratulate her on being so brave to try and take something like that on and try and look at it in the analysis that she's done. But just to give you a few different examples of what it looks like internationally, I just picked 3 countries. So in the UK, the Royal College of Nursing actually has some very good information up on this. They have both independent and supplementary nurse prescribers. And this is actually a well-embedded program in their healthcare system now in the UK. Most of these prescribers are in the community. But they have to have an accredited course through a university, so that is recognized by the Royal College of Nurses. Okay? These nurse prescribers are not necessarily nurse practitioners. Okay, the UK has gone a little bit of a different route in terms of recognizing nursing roles. For example, I have a colleague in the UK who is one of the continence advisors, who's a master's prepared nurse, who is also a nurse prescriber. So people can assume different roles. It's a different form than what we're familiar with. We are also seeing advanced nurse practitioner programs developing in the UK, and as well as clinical nurse specialists. And both of these groups, again, can opt to take or become nurse prescribers as well. In Canada, again, we have a history of, with our rural remote, of having nurse prescribers, and that's certainly where our nurse practitioner movement started in this country many years ago. And we have in virtually all the provinces now, I believe, legislation around nurse practitioner roles and prescribing. And we have moved to a master's level of preparation nationally for that. In the U.S., the nurse practitioner role is a very long-standing, well-embedded. Like Canada, prescribing and the components that go with that, including the assessment, diagnosis, and management, is part of nurse practitioner education. And the U.S. is moving from their master's into the doctor of nursing practice that you might have heard about. Nurse prescribing has been examined in several systematic reviews. I'm not going to go through a whole bunch of individual studies for you, but I'll just talk about these 2 systematic reviews that have really been good overviews of the literature, so I think it's always a good place to start, again, if you're interested. And I've given you all the references at the end, and then you can look at the individual studies. Both of these are getting a little bit old now, but Crozen, 2011, she did not differentiate between RN and nurse practitioner prescribers because she was looking internationally, and the roles become so muddy, and we have different titles and different legislation. But she considered all nurse prescribers in her systematic review and concluded back in 2011 that in most countries the medical profession still remains in control of prescribing, even though we do have pockets of nurse prescribing. And Gielan is the other person that I mentioned in 2013. And again, she included both RN and NP prescribers in the studies that she included in her systematic review, but she compared this to, nurse prescribers to physician prescribers. And some of her conclusions are that nurses prescribed in ways comparable to physicians, so in terms of safety and quality, but depending on the study that you looked at, sometimes the doses were different, what a physician would prescribe rather than a nurse would prescribe. And that wasn't always less. Sometimes it was more, so a whole variety. One of the problems that she identified, though, is we still don't have really good literature on this. A lot of the studies did have methodological weaknesses. So hopefully one of them will take up the cause and update some of that work. So why are we thinking about nurse prescribing or RN prescribing? Now I'm going to talk about RN prescribing, not nurse practitioner prescribing. But why are we talking about RN prescribing here in Canada? Well, a number of reasons have been put forward. First of all is the big one, access to health care. Right? So if you know, in most of our provinces, there's a real issue around primary care access and getting timely care, and extending prescribing rights to registered nurses is seen as one of the potential solutions to some of our problems with access. Access is also a problem with certain populations, such as vulnerable populations, rural and remote populations. To meet the health population needs is another reason that's been put forward, to improve patient outcomes, and that's not to imply that the physicians aren't good prescribers or the nurse practitioners aren't, but when we look at outcomes for patients, it goes really back to access too, right? So if you have time, hopefully if you have timely access and you have well-educated providers, you will have improvement in your patient outcomes. And one of the biggies that we hear the words tossed here and there all the time is that we need to make sure that our registered nurses are working to their full scope or even to an expanded scope of practice in this country. So several moves have happened of significance in Ontario, our most province with the largest population. The Registered Nurses Association of Ontario had a primary health care report that came out in 2012, and their recommendations came out in favor of authorizing registered nurses to become prescribers and also to communicate diagnoses and order diagnostic imaging. So things that have been traditionally in the purview of the medical profession that have become some of the things that nurse practitioners do are now being looked at as what role would registered nurses play in this. And then we've had little pockets, and I just have to put my plug in for Alberta because that's where I live. So we've had little incidents, and I'm sure we could find many of these across the country. Back here in Alberta in 2012, we had a terrible influenza epidemic, and they needed to vaccinate people very quickly, and particularly to prescribe the preventative medications, the antivirals. So that actually came as a specific ministerial order here in Alberta allowing a select group of registered nurses to prescribe the antivirals. And we've just recently had another example here in Alberta that's occurring across the country, and that is registered nurses being able to prescribe the naloxone for overdoses to prevent deaths. So the Canadian scene, we do have a framework that has just come out in 2015 from the Canadian Nurses Association, available on their website, so you can download that. And it is a framework for registered nurse prescribing in our country. It is developed by the Canadian Nurses Association, and they do acknowledge in the preamble that they did have meetings with the Canadian Council of Registered Nurses, or the CCRNR, and we're in agreement, although the CCRNR is not an author of this document. So it's been an interesting journey the last couple of years. With the changes here in Canada in legislation, healthcare professional acts, many of you are aware, especially if you're from Ontario or BC or some of the other provinces, that in some provinces that you can no longer be an association and a regulator, right? That's why the CRNBC had to split. It's why quite a few years ago we have the RNAO in Ontario, which is the professional organization, but the College of Nurses, which is the regulator, the person who gives you your license and makes the rules, or the people that make the rules. So I think it's significant in this document. So the CNA is really a representative of an association of associations in many ways now. So I think it's significant that they did go ahead, and I think it's a good document they've put forward, but it'll be interesting that because the CCRNR, the regulators, were not authors on this document, I'm not quite sure how that all will unfold as things come through. However, it is a worthwhile document to have a look at. It is well written. The vision is that we will see registered nurses prescribing a limited range of diagnostic tests, medications, treatments across designated settings using clinical decision tools. And one of the valuable things I think about going through this document is that it is quite detailed in terms of laying out what they call the structure, competence, and practice. And it really helps you understand how complex it is to put something like RN prescribing in place, because we need legislation and we need to have then the education component put in place and then monitoring and evaluation as well. The legislation is complicated, of course, in our wonderful country, and I am such a proud Canadian, so I always call it a wonderful country. But we have this really, little quirky thing called our Constitution, and what do the provinces control? Healthcare, regulation of professions, and education. Okay, so that's why we end up so often with such a patchwork in this country, because even though we can come and have these great consensus documents, oftentimes it does fall to the provinces to make the decisions, and those regulators who are under the provincial legislation to finish off the rules. So the CNA framework, going back to that from the CNA, so what are they recommending in this document, the educational requirements being? They're identifying that it should be RNs with baccalaureate or higher education who've achieved what they call the competencies for an RN prescriber in the province or territory where they are registered. The role is to deliver a diagnosis, order, interpret a limited set of diagnostic tests, prescribe and dispense limited range of pharmaceuticals, and perform a specific procedure, or perform specific procedures in terms of management within their legislated scope, which is going to vary from province to province. And they do recommend in this document the use of clinical decision tools. So these are the kinds of things that we're really familiar with in terms of protocols and algorithms and those kinds of support documents that we can use in our clinical practice. So here's a question: will the RNs and NPs compete? Well, most of the documents that I read in preparing this make an argument that it won't be a competitive situation because there'll be a difference in the prescribing. So the nurse practitioners tend to have that independent prescribing role and go through a different education process to achieve that. And the RNs will be a much more targeted prescribing role. So they're saying they won't compete, but I do have to tell you that there are sensitivities, and particularly in areas where the NP role is still struggling to be established, and my province is one of those. so just to make you aware of that. So the CNA framework is really nice, and it's colorful, and it is good. As I said, I think it's worth a read because it really shows you that it's so intricate and how many things have to be put in place before we can get to this type of change in our healthcare system. But the horse is already out of the barn on this one. So even though there's been an attempt to make a consensus document because of the way our health system works and because of the way our legislation works in this country, different provinces are ready at different times, and they've already moved on that. Okay, so some provinces have already implemented a model of registered nurse prescribing, and we are seeing our usual beautiful Canadian patchwork quilt start to appear on this one. Okay, so I went in, I took the CNA framework has a very nice table at the back of it, Appendix A, I believe it is, and they went through in 2015 to look at where each of the provinces were, and I went through all of the provincial regulatory body websites and some ministry documents where they're available to try and give you an update to that about what's happening across the country. So in Newfoundland and Labrador, for a very long time they have had, because they have lots of rural and remote areas, they have had legislation and policies in place that registered nurses can provide. It's usually dispensing medications and, again, using some of those kind of clinical protocols in order to provide guidance for those. This is authorized by the employer. Okay, so it depending on your health region or your hospital in Newfoundland, Labrador. The document, however, it comes with a caveat. It is a 1999 document, and their professional association, I see our Newfoundland nurses, is going through that document now. So I'm suspecting that we're going to have an update of that work coming out. Nothing's posted yet, so obviously under discussion. Okay. Newfoundland Labrador also is a province that still has medical directives, and they have a document on medical directives and pre-printed orders. Again, 2008. Most of the provinces are moving away from medical directives and from delegated medical acts. Okay. Because our legislation really recognizes us as registered nurses, that we take ownership of our own practice, right? And rather than working under a delegation of a physician, we need to work as professionals within our scope. So in Nova Scotia, there's nothing yet in place here. They have an updated medication guide that is posted on their website. And I did have an opportunity to chat with a colleague of mine the other week when I was in Toronto. And she is with their college. And she said it's sort of something that's in discussion right now. So, but they haven't really made any attempts yet to do anything formal in place. In New Brunswick, again, we don't have anything formal in place yet, but they had a very interesting virtual discussion on their website. So certainly the chatter is happening in that province about changes that might take place. In PEI, nothing is in place, and they didn't have anything on their website that would sort of help me to understand where they might be in that. In Ontario, again, RN prescribing not yet in place. However, things are rumbling and happening here. There is that 2012 document from the RNAO that recommended authorizing RNs to prescribe, and in 2015, the ministry asked for a consultation to the Health Professions Regulatory Council on models of RN prescribing. That report was submitted at the end of March. It is not posted yet in Ontario, so it's not a public document as yet. But certainly there has been a commitment by the Ministry of Health in Ontario that they will be looking at what role registered nurses might be playing in prescribing. In Quebec, in January, they put their model in place. So theirs is to very specific situations and patient needs. And for a start, they have selected these areas: wound care, public health, particularly tobacco cessation, and sexually transmitted infections, and common health problems, especially that their public health nurses might come across, such as candida in infants and new mums, okay, or a nausea, uncomplicated nausea and vomiting in pregnancy. They are requiring 8,400 hours of experience in community health or in long-term care for wound care. Plus, they are just working on some approved university-based courses that the nurses who want to become prescribers would have to take. In Manitoba, they also are they're one of the first out of the barn here, so to speak. They're calling it a registered nurse, AP, so authorized prescriber. Theirs just came into place in 2016 as well. And the areas that they're going to concentrate on first are travel health, reproductive health, sexually transmitted infections and bloodborne pathogens, diabetes, and health prescribing, screening, and diagnostics. Okay. So their authorized prescriber program is under development. So they've got their legislation in place and the rules and regulations. But their program, their education component has not yet been rolled out. And they acknowledge they're one of the few provinces that sort of give you a little bit of insight that on how additional areas might be recognized. So they indicate that additional areas will depend on public need and impact. So they are not requiring a baccalaureate in Manitoba, but they do need employer endorsement to take the course. So again, it is going to be tied to employment in Manitoba. Saskatchewan is also just coming out of the barn. They are calling theirs an RN with additional authorized practice. You can see what a patchwork this is, right? We've also already got a whole bunch of different titles going on here now. So anyways, so their documents are posted. From my reading of the documents from Saskatchewan, and I didn't have a contact in Saskatchewan that I could get to in time to confirm this. So if any of you are from Saskatchewan, have some insight in this, please speak up. But it appears that they are really concentrating on their northern RNs at the moment. A lot of those RNs have been, I guess you could call it prescribing for a while under sort of a medical directive or a delegated medical practice, which is being phased out in Saskatchewan. And so they have some impetus because they have lots, again, of rural remote up north. And this is a role that registered nurses have been taking on for some time. And they need to make sure that there's patients aren't losing out because legislation is changing. So they're going through a process right now for their nurses who up north who have been prescribers to do a PLAR, or that's a previous learning assessment. And if they don't want to go through that, then they have 3 courses in place: clinical drug therapy, health assessment, and clinical decision making. That will be starting to be offered for this group, offered to this group of nurses, so they can make sure that they are not, as I say, creating a gap in service during this change. Okay, they will be using clinical decision tools. I couldn't tell if they were developed or not, or they must consult with a physician or a registered nurse who's also a nurse practitioner. And again, employer policies need to be in place in this setting, so tied to employment. Here in Alberta, we have a draft of the standards and competencies that has been circulated for discussion and feedback. Within that document, the plan is that RNs will prescribe in specific clinical practice areas. It will not be transferable, okay? So like some of the other provinces, whereas the nurse practitioner license, it's an additional license from your regulatory body that is transferable, and we've worked hard on transfer across the country. This is going to not be transferable from one setting to another because it will be tied to an employer. Alberta is looking at a minimum 3,000 hours of experience as a registered nurse, with 750 of those hours in the area of specialty practice for which the prescriptive authority is being requested. Again, employer support is needed. You have to have the clinical tools in place in the setting, so the protocols and the algorithms are going to have to be part of the package that goes forward in Alberta when people apply for this. And you will need to have a collaborative relationship with an independent prescriber, either a nurse practitioner or a physician. And the document just says education will be whatever is approved by provincial council, which tells me there's not much there yet. So we don't know what the education in Alberta will be. BC is really leading on RN prescribing. They have their certified practice model in place, so it's the RNC. And interestingly enough, the way that they've rolled out nurse practitioner practice for certain clinical situations, nurse practitioners must also go through part of this process as well in order to prescribe in that area. In BC, the nurse practitioner registration tends to be a little bit more of that second model, that supplementary model. They're independent in some areas, but they also have to work with collaboratively with physicians. So they have approved their first decision support tools, the contraception management, remote nursing, RN first call. So again, this relates to hospitals or emergency rooms that tend to be in more remote areas, and sexually transmitted infections. Those decision tools, interestingly enough, instead of being developed in the work site in BC, those are actually all developed or posted on the RNBC website, and they are very, very detailed. So they've put a lot of work into this already. They do have approved courses in place that nurses will need to take in order to qualify for this. Implications for nurse continence advisors in all of this. Most provinces are either restricting the registered nurse prescribing to very specific programs or roles, and oftentimes they are tied to community roles or some of these initial forays into RN prescribing, or the legislative changes are still under consideration. So we have people at different levels of readiness and implementation. So my questions to think about here for registered nurse NCAs is, should the RN NCAs prescribe? Is this going to be possible in all of the provinces, given what I just ran through in terms of where everybody is? And what should they prescribe? When I'm not on sabbatical, part of my life is I'm the coordinator for the NP program out at the U of A. And this is what I tell my students when they first start their NP program, right? Because they're all really excited. They want a prescription pad. Anyway, as we all know as nurses, and they are registered nurses, prescribing drugs is a lot more than just having the prescription pad, right? We have to know a lot about pharmacodynamics, and in particular receptor theory, which is a big component of how a lot of medications that we use now in practice work, and really understand how does that drug work to get that effect. We need to understand the pharmacokinetics, how that drug moves through the body, okay, and is metabolized and excreted, really important concepts in pharmacodynamic or pharmacotherapy. We need to understand the pathophysiology of the disease, right? So what's the targeted condition? And on top of that, because most of us deal with very complex patients, what about the comorbidities? So it's not just the diabetes, right? So it's the diabetes and it's the hypertension and, then it's the person with diabetes who also has Parkinson's disease. And so we work with really complicated people in terms of their health issues. We need to know something about age-related changes because for many of us, we work with an aging population, and that's the demographics of our country. Potentials for drug, food, drug, environment interactions, and then very important, the side effects and potential adverse reactions. And again, I know I'm not meaning to speak down in any way, because I know as registered nurses we have education in this area and that you are already working with your patients and talking about these things, but it takes on a different light is shone on it when you're the one that actually has the pen in hand and takes the responsibility for writing the prescription. So my first question, should RN NCAs prescribe? Well, personally, I think that we can make an argument that for some RN NCAs, this makes sense to take this on, and it could be a part of their role. I think about my colleague in the UK, right? So who is a specialist in her area, also has this type of role, okay? But we do need to consider what your background experience is, your area of expertise, the focus of your clinic or service, and what kind of mechanism for the lab and DI and the prescribing outcomes, because this is not just going to be prescribing, that prescription pad, right? Again, that I have to tell my nurse practitioner students. When you order lab and DI, you are the responsible healthcare professional for those. So you need to make sure you're in a situation where you're able to follow those up and communicate any findings to patients that need to be communicated. And there was a very sad case that hit the news this week about the lady I don't know if it went national, the lady who had a spot on her x-ray, and it kind of got lost in the emergency room paper for a year, and her cancer wasn't picked up. So when you are ordering and prescribing, these are the kinds of things we need to think about, and how, if I'm going to do this and I have a responsibility, how do I make sure I'm in a situation where I can do that, right? Where I can fulfill my professional responsibilities. Education on clinical decision-making, diagnosis, diagnostics, advanced therapeutics will be needed. This is not covered in undergraduate nursing programs, okay? And although we may gain a lot of this as we gain experience as registered nurses, what legislators are going to go back and look at, and regulators, is what's the baseline, okay? And in most of the programs in this country for registered nurses, this is not covered, Okay, so there is going to, as Saskatchewan has put in place, some of those courses on assessment, a more advanced course on pharmacotherapeutics, those kinds of things will probably need to be put in place. And it's not the RNs being picked on, because the NPs also had to do this. We had a change it to the CDS, the Controlled Drugs and Substances, after 15 years, that allowed for nurse practitioners to prescribe controlled drugs and substances. And as that is rolled out in the different provinces, even if you were the most experienced nurse practitioner on the pain management team, you still had to do a course on CDS prescribing, right? So they look at the baseline, and then so that those education pieces will definitely need to be put in place. Is this going to be allowed in all provinces or possible for NCAs? Well, the prescribing model, and within that prescribing model, the targeted populations, clinics, conditions are really going to be the purview of the provincial regulator. So we saw in Quebec, they've taken some very specific pieces now, first of all. They have not got anything up on their website, which I did translate because my French is so rudimentary. But on whether or not they're going to be, what kind of allowance there's going to be for additional prescribers to come on board in Quebec. However, Manitoba gives us an idea that they're going to look at issues of access, issues in terms of need, so there might be possibility in Manitoba that this could be, you could formulate an argument for NCA prescribing in that province. In Alberta, we just like to leave everything wide open, and so I think actually in Alberta, if the regulations go ahead with the documents that are currently under circulation, I think there is a good chance. In BC, again, they've picked really specific and targeted conditions. They don't provide on their website any information about how you would make an argument for an additional population to be addressed. So that one I'm not sure of. But in pretty well all of the provinces, those clinical decision-making tools will need to be developed. And the last questions that came to my head is, what should RN NCAs order and prescribe? Because, there's a whole weird and wonderful group of drugs and tests and all sorts of things that we could be thinking about, right, in terms of our practice. And I just put a few things that came to mind there in terms of, well, so there's basic labs, and I have to say probably, if we really look at a lot of practice, you're probably doing this already. It's just that you don't have the legislation in place, right? You're making the decision to send a lab, right? But the legislation isn't there. What kind of DI test should RNs be authorized to order? And this will be an issue when we brought the NPs in the country. Certainly the radiologists put some big barriers up in different provinces around NPs ordering DI. Most of those barriers, I think, have been overcome, so we have to anticipate that and, again, prepare an argument. Why is this? And be judicious about what it might be. And then what are the medications? What are the drugs we might expect an RN NCA? So certainly, I think about laxatives, and again, when we look at practice, probably this is happening in a lot of places already without the legislation in place, okay? But bowel routines, right? So, and vaginal estrogens for urogenital atrophy are very commonly prescribed. Many of our colleagues are experts in this area, but you're probably in a position where you have to run down the hall to get a prescription for this at the moment, right? To have a prescriber sign it, yeah. The other kind of big groups of drugs that we use in continence are the antimuscarinics and now the new beta-3 agonist for overactive bladder. These often affect the autonomic nervous system, And we have to think really carefully about our complex patients whenever we're starting to think about those kinds of drug groups. The alpha blockers and the 5-alpha reductase inhibitors for the men with benign prostatic hyperplasia that's leading them to have lower urinary tract symptoms. Again, thinking through complex issues. You know, do I really want to prescribe tamsulosin in this patient who has a problem maintaining their blood pressure and has had falls? And then we use in our clinic for nocturnal polyuria low-dose desmopressin or arginine vasopressin. And again, complex patients, and we need to think about that in terms of how we do introduce these things in the safest manner. And also devices are going to come here, as I said, in some areas, okay? And that's going to vary from province to province again. Again, when I was looking at the documents, I was actually really surprised in the BC documents. It's really specific around pessaries need an order. Whereas I think in our practice here in Alberta, that's really become a decision of specialized nurses. And same in Ontario, it needs an order. Yeah, so we have a whole, it doesn't need an order, Ontario. Okay, yeah. So we have, again, a patchwork, you know, across the country about what is allowed, what is current, and how things might happen. So I thought we should just play here for a minute and talk about a couple of cases, because I always love clinical practice. And so first case, I have an 86-year-old female. Okay, you've put her through her assessment. The diagnosis is a mixed urinary incontinence that is urgency dominant. Her previous medical history includes hypertension, hypothyroidism, osteoarthritis, and Parkinson's disease. So I work in a geriatric continence clinic. This is so typical of our patients, okay? So, yeah, they've got a lot of different issues going on. Medications already on board for this patient: hypochlorothiazide, ramipril, levothyroxine, acetaminophen, levodopa, carbidopa, okay? We've tried some of the conservative approaches, which always are our first, right? The prescription pad comes out last, right? Unless you're prescribing exercise and weight loss. Right? So, but you know, our conservative therapies are our first line therapy. Okay. So, is there any other information you want to know about this patient? So, she's got urgent continence. Yeah, maybe we'd like to do a bladder diary, because maybe we'd like to a little bit more detail. Yeah. And a bladder scan. Yeah. That's a good, so we need those kinds of details in terms of informing us. Because if we just looked at this and said, okay, urgency dominant incontinence, well, that's an antimuscarinic. If we hadn't done the bladder scan, right, yeah, and got a post-void residual, we could potentially be giving this to someone who's not emptying their bladder well, okay, which is, as we know, a condition that occurs with increasing frequency as people get older. Okay, other things. Yeah. Yeah, that's right. So I haven't given you a lot of information on this. Yeah, absolutely. And I think that's really important, Jennifer, right? Because I find a lot of times when people come to our clinic, someone, and I'm sure many of you find them too, that someone has never bothered to do a proper continence assessment that includes a physical examination, and they've been throwing medications at these people. So all of this goes into that whole pathway of, we need the assessment piece. We need that clinical decision making, the critical thinking, and coming to a conclusion, coming to a diagnosis needs to be based on a good history and a good physical exam, right? Okay. So the other thing in this person that would come to mind for me here, I have an 86-year-old. Okay, we know that dementia increases with age, okay? So, and in the group 85 and older, our quote-unquote oldest old, we have probably about 30% of these people have dementia going on. That is going to influence my prescribing, okay? Because I am not going to give oxybutynin to someone who has cognitive impairment, okay? They'll be in the hospital with delirium. So I need to know something about that, a little bit more about that background. And if it's not there, then we need to make sure that we make the referrals to get those if we are suspicious of that. The other thing that I would put forward that you want to look at with this lady, she's already on quite a few medications, okay? She's 86. What else declines with age? Renal function. Yeah, so that's right. You're right. She's on hypochlorothiazide, right? If she's not taking her medications inappropriately, the point was maybe that the electrolytes are a little out of balance too. So we do need to be thinking about these in these really complex patients. So coming back, if we thought that she didn't have cognitive impairment, okay, her renal function was good, we did an appropriate exam, ruled out other conditions that might be contributing to her symptoms, and we decide to treat for urinary urgency, what kind of guidelines exist to help us make those decisions about what we prescribe in an older person? That's the start low, go slow, that's right. There's the good old Beers criteria. But in 2014, there was also a FORTA guideline put forward, and I don't think I put that on the list, but I can add it, and if you want to have a look at that, which is prescribing for urinary overactive bladder in older adults, okay? And the only, oxybutynin is the big no-no, okay? We know that, okay? There's no evidence around solifenacin. That doesn't mean it's a bad drug. It's just that no one's done the studies. But the only medication that we really have any studies in older people is fesoterodine. So based on that, fesoterodine often becomes maybe our drug of choice in this population at this point in time, because that's the evidence that we have. I'd also think about her Parkinson's disease, and although we don't have a lot of the evidence yet, the other one that we're using more in our Parkinson's patients is the beta-3 agonist, mirabegron, because we can avoid the anticholinergic side effects using that. So thank you. That's another thing we need to think about when we're prescribing. Absolutely, we need to think about costs. And that's going to vary from province to province, again, depending on what kind of drug plan for our seniors, and what the formulary says. In Alberta, we have a STEP program. They tell us that we're supposed to use oxybutynin first, but we've had a lot of success out of our clinic making the argument that the person has been diagnosed with Alzheimer's disease or another dementia, and that using oxybutynin is an inappropriate prescribing choice. And they've been allowing us to skip that now. But you're right, it will. And mirabegron is the new kid on the block, and it's not covered yet in all of the provinces, right? So yes, cost. It's on-off, yeah. They get on-off phenomena with their medications. So I think that I have another case, but I'm running out of time here, so I think I'll leave it. I can certainly share my slides so you can have a look at the other case and just kind of play around about it and think about it in your mind about what you might think in terms of that case. So my last thoughts here as we're finishing up. What do we need to think about? Well, first of all, I think that as NCAs, we need to think about targeting specific common conditions that you manage in your clinic. What is your specialty clinic? What do you focus on? You likely need to build those clinical decision-making tools, because in the only province that I saw them posted on the regulatory website was BC, and it looks like most of them expect those to be developed in the employment situation. So you need to build those clinical decision-making tools that say, so we're focusing on women with urogenital atrophy, right? Okay, so what do we need to do in terms of what lab makes sense? What's my justification for those? Are there other DI things that might come into play when we're looking at that condition. And then what are the pharmacological and non-pharmacological interventions? Because just like my NP students, it's not all about the prescription pad, okay? All right, we need to think about the patient complexity and the availability of interprofessional support, and as well communication back to primary care providers. So if you're working in an area and you're seeing patients that are whether they're complex geriatric patients or complex younger patients with multiple comorbidities, and you haven't got a great deal of your own depth of experience, your experience comes from somewhere else, you need to think about, is that an appropriate area for you to be prescribing? And if it is for the NCAs, what kind of supports are in the background there? So do you have a geriatrician? Do you have a nurse practitioner who has a specialized background in geriatrics? You need to ask if the employer will support the practice, because as we saw in the scan across the country, that is a requirement. That RN prescribing is not going to be transferable from setting to setting. It will be tied to very specific areas and probably through specific employers. And then familiarize yourself with the regulations and processes in your own province, because mine was just a scan of what's available. So if you think that you're in one of the provinces where you know this is coming, or you want to think about, is this a role for the NCAs in your province, I'd make an appointment with some of your people at your regulatory body and talk to them about what the processes are. And if NCAs were to put forward an argument in, Clinic X, what would be involved in terms of putting that forward and putting forth the safeguards. So I think I'm right at the end of my time. We do need to go see our wonderful supporters and display booths. So thank you very much. So.